We're talking about the medical mismanagement of chronic pain. Why does it persist? How did it happen? Why is it so powerful based on its persistence? How can this model of pain management be so ineffective and yet so stable? Like, why haven't they changed it? So where's the error that locks people into this model even though it doesn't work? That's the question that I'm trying to answer here. Hello, everybody. Dr. Vasquez coming to you live right now. Today is the 9th of January, 2024. I hope that all my machines are working. And I'm going to record this obviously right now. And I'm also happily willing to admit that this is not the best time for me to make this recording. But I think it's the appropriate time, not the best time. So I'm going to go ahead and dive into this. And I'm going to use a few different methods of kind of recording these ideas. And, you know, ultimately I may have to re-record this, but I imagine perhaps not. But we'll just see how it goes. I've had a lot of ideas lately, and I had a lot of ideas that kind of came together maybe let's say Saturday morning. But then, I shouldn't say unfortunately. Unfortunately for the ideas, perhaps, but fortunately, maybe for the bigger picture of my life, we had family visit over the weekend, and it was a long weekend, so that's why I'm only getting to this right now. So, for me, a lot of these ideas kind of matured about 3 days ago, and then I had to kind of put them to the side while we had friends and family visiting, and we were doing a whole bunch of different stuff, from archery. Of course, if we're at my house, we're going to shoot archery, which in this case also meant almost taking the skin off of one of my fingers, which wasn't the intention, but that's what happened. So let's see: archery, barbecue, fireplace, a lot of food. Well, not that much food, but obviously food. And some successes and failures along the way. You know, sometimes the barbecue went well, sometimes the fire was too hot, we had too much flame, we didn't have any charcoal, we played games, and I'm used to winning when I play games, believe it or not, and you can probably believe that that's true. And in this case, I didn't win, and I had to deal with that. I was like, wow, I really suck at this game. And I had to sit there and just accept the fact that I sucked at that game at that time, and not run away from that experience, you know. The other thing is, along the same line, is we played a few games of chess, and I actually lost one, but I lost to a guy, a young man who I like and who I'm mentoring. So I had to, instead of thinking of it as losing, I had to think of it as I'm gaining the opportunity to show him, as a young man, that it's okay to be competent, confident, and still lose and still be okay with that happening. So I had to turn it into something good. Anyway, the point that I'm making relevant to this video is that I've been completely distracted in a bunch of different directions, including stupid stuff like, you know, playing with remote control cars, which of course I have no interest in, but I do it within a certain social context. So I've been hugely distracted and sitting on top of these ideas. And so I want to bring these ideas to what I think is going to be the next level of development right now, even though it's not going to be perfectly polished. And the other thing is I'm going to show a video that I just saw yesterday, I believe, that really helped me make sense of this. So, you know, on the one hand, I've had to sit on these ideas and not advance on them for 3 days. But actually, just last night, I'm remembering the exact time right now, just last night, I saw a video that really put this thing together. So in the other sense of things, the 3-day delay was good because, even though it was kind of a 2-day delay without any progress, the third day actually helped me make progress. So what am I talking about? Among many different things. I'm talking about the medical mismanagement of chronic pain. So this is something that I've been kind of observing, and I've been developing language for it as I've continued thinking about it. But I think now I'm at the point where I have enough language on this topic to understand it in the way that I want to understand it. So, for those of you who don't care about the medical management of chronic pain, you don't have to watch this video. But for those of you who care about chronic pain and or care about kind of the philosophy and psychology of how we understand things, then I think that this video will have some value. So the concern that I have, as many of you already know, because I just said it right now. Let me pick. I guess I'm going to start with black, and then we'll move through different colors. So I'm just going to write these things out spontaneously and continue to develop this. I'm going to try to go a little fast, or at least I'm going to try to push myself to go fast, whether it happens or not, so I can make this video in as short a period of time as possible. So let's just start diving into things, and we're going to see how it goes. If this video ends up being horrible, then we'll call it the first draft, and then I'll do a more polished version later, which I probably will. But I want to go ahead and nail down some of these ideas, because this is going to be 90% accurate, and 90% of the finished product is going to happen right now, even though it's going to have a little bit of stopping and starting as I go through it. Okay, so here's my concern. My concern is about the medical. This should be working. Let me reconnect my pen here. I don't know why it disconnected. My concern and the topic of discussion right now is what I call the medical mismanagement of pain. Sorry. Medical mismanagement of chronic pain, not acute pain. I don't have any problem. I don't believe. I don't think I have any problem with the medical management of acute pain, except for migraine headaches necessarily, and cluster headaches. Those are not appropriately managed medically. But I'm going to focus on the concern that I have about the medical mismanagement of chronic pain. That's the concern. That's the topic of this discussion. So, proof of the medical mismanagement of chronic pain was the article that I reviewed last week that I'm looking at right now on the screen. That was published by the American Academy of Family Physicians, and this was published in 2021 in their journal, American Family Physician. So I cited this article in the review that I did last week. The title of the article is Non-Opioid Pharmacologic Treatments for Chronic Pain. And I might, in the same context, look at another article that they published, I believe, a year before, and that would have made it 2020. It was 1 year plus or minus. We may look at that article as well. And that was non-pharmaceutical management of chronic pain. I think maybe I'll try to include that if I think about it. I haven't pulled it up, but I guess I could. That article was also disastrous, but it may bear looking at. I guess part of the reason I don't want to look at it, I don't want to look at that article, is because they didn't talk about nutrition. What they focused on in that article was mostly physical interventions like massage and Tai Chi and deep breathing and maybe cognitive behavioral therapy and a little bit of spinal manipulation and exercise. But they didn't talk about nutrition, which of course would have been a big battleground for me and therefore very enticing. But because it didn't talk about that, the other stuff I don't really care about that much. I mean, the fact that they talk about like exercise for chronic pain, I mean, people should exercise anyway, whether they have chronic pain or not. So the fact that virtually all studies show benefit of doing some form of exercise for the treatment of chronic pain, that doesn't come as any surprise. And of course, people with chronic pain should exercise because they tend to be less mobile anyway. So therefore, exercise is even more important for them to compensate for their otherwise lack of mobility. So it was just kind of a zero article. I'll try to pull it up here. I guess maybe I'll go ahead and pull it up right now. Okay, well, I'll go ahead and pull it up right now. I'll probably have to blank out the screen for a moment just so I don't show all of my folders and things. But let's see if I can find that article very quickly. Non-opioid, no, that's the same one I'm looking at right now. Non-opioid pharmacologic treatment, that's the same one. Chronic, here it is. Yeah, chronic musculoskeletal pain, non-pharmacologic, non-invasive treatments. Well, they could have talked about nutrition. Nutritional supplementation is not truly, it's not truly invasive. I mean, obviously the supplements are taken internally. Depends on what's meant by invasive. Sometimes invasive means surgery. So if they're talking about non-invasive, meaning non-surgical, then they could have talked about nutrition here, but they didn't. So this was published 2020, American Academy of Family Physicians in their journal, American Family Physician. And this article for me was just a waste of time, basically, but we'll look at it anyway. Waste of time compared to what I want. When I read research, I want meat and potatoes. I want stuff I can dive into, learn from, sink my teeth into. And some articles are just so mamby-pamby that they don't say anything new, they don't say anything innovative, and so I just feel like it's like, This article, even though I don't like it, referring back to this article, non-opioid pharmacologic treatments for chronic pain. Even though I don't like this article, of course I don't like it. But it's actually quite excellent. For what it is, it's an excellent article. It's not what I want to read necessarily, but I did read it because if I'm going to dislike something, then I have to, of course, study it so that I can either justify my dislike for it or learn and have the experience of saying, wow, I was totally wrong about that. I started this article hating this topic, and now it's my favorite topic. That could have happened here. It didn't happen here. I don't expect that within the remainder of my lifetime, which I hope is a long time, I don't think I'm going to ever change my opinion on this, but maybe I will. This was an opportunity for me to change my opinion on this topic, and because of the truth of the matter, it's just not going to happen. Because like I said, they presented their position perfectly. And what they ended up showing here, as I said previously in the other review that I did, what they ended up demonstrating here is that their approach is a complete failure, a nearly complete failure. So that's my concern. Medical mismanagement of chronic pain. We'll look at this article again in a moment, but I'm gonna get into. I kind of have to talk about the other video that I did last week as well for this to be complete. So the other video that I did was a review from Harvard Medical School in a presentation that they called the science. I think they called it the science of pain management. I showed you that video. I went through the entire video, kind of giving my feedback on that. And that likewise was a complete disaster. So let me go ahead and organize my thoughts here. So we have to look at the article that we're looking at right now. American Family Physician 2021. The other article was American Family Physician 2020. The other source that I've reviewed recently, among many, I only talk about the ones that are worthy of talking about. Some of them are so abstract, I think, for most people's conversation around this. Or let me say that slightly differently if I can. I think some of the articles I've been looking at are so tangential to this topic in the way that most people would perceive it, that they would consider it to be too abstract or too ephemeral or whatever. For example, if we look at this article from Trends in Cognitive Sciences, this is a good example of the kind of stuff, kind of research that requires consideration but not necessarily inclusion. So this article, 2017, I believe, 2017, is one of the articles I've reviewed recently in trying to get a grip on this topic and find solutions to it. Part of what's at stake here, or part of what's at question, is how ultimately do we perceive reality globally, and then how do we, in this case I'm talking about the management of chronic pain, because what I have perceived, and what I continue to perceive in the medical management of chronic pain is that there's some type of error occurring. There's some type of error occurring, maybe from multiple sources, but what I'm trying to do as a doctor, tertiary researcher, I guess, and presenter, etc., I'm trying to decipher what is the problem here. So, for example, in this article and some others that were published in the computer science literature, I mean, I haven't taken a computer science class since I was 10 or 12 years old or something like that. But I did read an article from the computer science literature, believe it or not, talking about artificial intelligence and how they were trying to teach artificial intelligence to correct the error that is presented in this article. So you'll see that just from looking at the title, then I'm going to close this article and move on to another one. You'll see from this title, Constructing Experience, Event Models from Perception to Action. Well, you'll notice that I annotated the title of this article 1 and then 3, because obviously, and I don't even know why they wrote this the way they did, because in between perception and action is what? I mean, I would hope that this is obvious, and that's why I don't know why it wasn't obvious to them in the way that they wrote this. But no being, especially human beings, but no mammal or no complex being goes from perception to action. Obviously, in between, there has to be something either solid, which we might call understanding, or semi-liquid, which we might just call judgment. But when they describe this event model as from perception to action, they kind of lost me in the title, because I was like, well, there has to be an intervening. Let me say that differently, because I don't like starting sentences with there. So in any high-level discussion of cognitive sciences, I would think that the conversation would have to include at least 3 phases: perception, judgment, or understanding, but let's at least say judgment. It doesn't have to be understanding. It just has to be judgment. And then action. The action could be right or wrong based on the judgment, but those are the three steps of, a basic event model. So I don't know why they put perception to action without including judgment. I suppose this is somewhat interesting sentence. Well, I'll go ahead and read it. Predictions are a powerful feature of human cognition. The brain appears to spend a substantial amount of its energy budget on predictive processing that puts it in a position to respond to predicted environmental features. I'm going to read the first half of that again. The brain appears to spend a substantial amount of its energy budget on predictive processing. Okay, so trying to think of something. And I guess I'll just mention this, even though I've thought about it for years, but this is actually part of what's missing from formal education. If you look at, and this is kind of a side note, but I have to make the side note, I guess, right now because it's been bothering me for about 12 years. If you look at, sorry, I can't remember the name of it in this exact moment. It's a little bit late. Usually I make my videos in the morning. Obviously right now it's getting kind of late. But if you study education, you'll come across this diagram that's a pyramid. When I edit the video, I'll put the pyramid in there and then you can see what I'm talking about. It's all about pedagogy and some stuff that I kind of hate, and maybe that's why I don't remember the name of it, because I don't really like this topic, because I don't think it's accurate. But they talk about kind of a hierarchy of educational processing, development, goals, tasks, objectives, things like that. Part of the reason I also hate this particular model of education is because this is what was popular at our medical school. And they actually had like banners and kind of a publicity event around this, but they called it higher order thinking, HOT, which I hated it. But the idea that's represented in this educational model is that, for example, memorization, memorization would be down here. And then problem solving would be up here. And this is a very well accepted model in education. I mean, this is probably one of the models, or this is probably the dominant model in various forms and schools of education. And so the stupidity among various stupidities of this model is that educators, not really educators, modern educators have tried to push students to the top of this pyramid by saying, oh, these are the things that have value, and these are the things that are stupid if you're going to be a clerk, or you're going to pump gas, or you're going to do something rather, less sophisticated. Then these are the things that those people focus on, like rote memorization. But the more cognitive challenging things are said to be at the top of this pyramid, which is starting to look kind of like either a boil or a volcano. Uh, so anyway, sorry, I realize this is a tangent, and I acknowledged it as such before. But for me, what I've hated about this is that it hasn't included anything about prediction. For me, the top of the pyramid should be prediction. For me, the goal of education, going through this stepwise sequence, not missing any of the steps. See, what they want to do these days in modern education is skip memorization and just jump to what they call higher order thinking, like problem solving and things like that. Well, for students, and this happened to us in medical school, and I see it all the time. If students don't have the discipline and the core knowledge that comes from memorization, then they don't have the fundamental materials for problem solving. And so what I've hated for decades, apparently now, about this model is that tasks like memorization get skipped because so-called modern educators want to jump to the top of this and say, hey, and we did this, for example, in medical school. In our ethics class, for example, we had problem-solving exercises applied to ethics, but we had never studied the fundamental core of ethics. Like we had never studied like the basic 4 principles of medical ethics, right? I don't even think they were ever mentioned in our class. So how the hell can these medical students who have never studied the core principles of ethics then engage in problem solving in medical ethics? And again, that's the modern education way of trying to skip the basic stuff, which they consider too primitive, even though we sure as hell had to memorize a bunch of other stuff in a very primitive manner. The crime of modern education is skipping the construction of a complex knowledge base with which one can then solve problems in a complex manner. And the other thing that has bugged me for decades is that they don't even talk about predictive ability as a consequence of education. For me, that's one of the highest goals of education, should be predictive ability, not simply problem solving, not simply multicultural perspectivism and whatever else. The ultimate goal of a high-level education should be the ability to predict. Not in some esoteric way, but in a way that's consistent with pattern recognition. So anyway, the brain appears to spend a substantial amount of its energy. The way this is worded throws me off every time, but let me try to flow through it a little quicker. The brain appears to spend a substantial amount of its energy budget on predictive processing. So why isn't if that's true, then why isn't predictive processing talked about in education? Why don't we talk about predictive ability? And why don't we try to develop predictive ability? Okay, thus, a re-representation that makes such predictions more accurate, more efficient, or both may be a worthwhile investment in the brain. Obviously, that's true. Thus, a re-representation that makes such predictions more accurate, more efficient, or both may be a worthwhile investment for the brain. Yeah. Okay, so here's another good quote from this article, and then I'm going to close out this article. An event model is not an arbitrary fabrication of the mind. To be useful, it needs to be closely coupled to the evolving state of affairs in the real world. I'm going to read that again, because this actually has application to what I'm going to talk about. An event model is not or should not be an arbitrary fabrication of the mind. To be useful, it needs to be closely coupled to the evolving state of affairs in the real world. That's actually, like that, I didn't like this article. It's 19 pages of density. But that one sentence, hold on. Well, that one sentence, at least for what I want to talk about right now, that one sentence is worth the entire article for me. Let me see if I can circle it. Maybe I can't. Maybe I can, depending on which program. Yeah, well, there it is. That's the sentence. That's the sentence for me of this article in the way that I'm going to apply it to the medical mismanagement of chronic pain. Okay. I told you this was going to be a painful start, and the whole thing might be painful, but we're going to make progress as I go through this. Maybe we already have made progress. Okay, so I have to talk about those two articles. I also mentioned and reviewed last week the article from Harvard Medical School. What they call it, the science of pain management, I think they called it. Oof, what a disaster. What a disaster. What a disaster. I may have to reference my own notes on that video just for the sake of completeness. Okay, what else? And then we'll talk about how the models are. So let me do that right now. Sorry. I'm not going to erase my mistakes very often, except when they're uncontrollably bad or unacceptably bad. So let's look at models. And so here's what I'm going to do. I'm just going to write it out very quickly. These two models of pain management, I'm going to reference, and I'm going to go back to my notes from Harvard Medical School. I'm going to pull up those notes right now. I'll have to blank out the screen and things like that because those notes are actually within a more comprehensive document, which I don't want to show to the entire world right now. But here, within that document, are my notes from this presentation, so I am going to pull those up right now. And then I'll make corrections later. Okay, so there we go. Okay, so let's talk about models. What I've seen in pain management books is they mostly talk about two different models. I'm going to show you two separate models right now. One model looks like this, and they say, well, pain is either nociceptive, or it's neuropathic. That's what they say. And they say for nociceptive pain, we have to use a certain category of drugs. Those were the same drugs listed in the presentation from Harvard Medical School. Or you have to use neuropathic drugs. Again, those were also described in the presentation from Harvard Medical School. So that's one very common model of the medical model of pain, which then becomes their springboard, so to speak, for how they manage pain. So they have to start with a model. This is one of the models that they use. From the Harvard Medical School presentation the other day, I have to go to purple right now, apparently. So from the Harvard Medical School presentation, what they said was, I think he said in that, yeah, I wrote it down. Right. So he used a slightly different model. The first presenter used a slightly different description. He said pain is either acute, chronic, or neuropathic. So that's, and these models can be merged together in the way that I've kind of done here. Most nociceptive pain can certainly be described as acute or chronic. Acute just means rapid onset, usually due to surgery or injury or trauma. And chronic has to be at least 3 to 6 months. And neuropathic is obviously neuropathic.
Now, what about the different types of pain? So we have acute pain, and acute pain signals tissue injury, just like I've told you. It says, keep it protected until all of the tissue heals. But at some point, in states where you have recurrent tissue injury, or in those where you've had permanent alterations of the nervous system, you can have pain that persists 3 months, 6 months. There are different definitions, but by and large, beyond 3 to 6 months, we call it chronic pain. And chronic pain can come from a recurrent condition that injures tissue over and over. It can have a waxing and waning pattern, or it can be chronic, persistent, and severe that never lets up. There are many different types of pain, but what underlies it is, what is the cause of the tissue injury? Now, there's a special subset of pain that happens when you injure the nervous system, and it's frighteningly common after injury. When you injure the nervous system, sometimes all the tissue injury heals. If you look at the person, if you look at the area that was injured, it looks normal. All of the tissue is healed, but there's persistent pain in that same distribution. We call that neuropathic or abnormal pain associated with nerve function.
So you can see that these are two ways of describing pain, either nociceptive or neuropathic. You can also describe it as acute, chronic, and or neuropathic, but these obviously these models kind of go together. In the presentation, so I'm going to look at my notes right now. In the presentation from Harvard Medical School, he described the treatments that they use in the medical model. Acetaminophen, just as an analgesic, NSAIDs, which are non-steroidal anti-inflammatory drugs. They're barely even anti-inflammatory drugs. All they do is reduce prostaglandin formation. Atypical drugs he describes, such as tramadol.
All right, but I'm going to focus for a minute on analgesic agents and their uses. Now, here's the range of what we have out there, and it begins with acetaminophen. It's a very good analgesic. We don't know exact mechanisms. We have some ideas of where it works in the central nervous system. It's different than the other drugs like ibuprofen, which we lump into a class called non-steroidal anti-inflammatory drugs. It turns out they're very effective pain relievers for mild to moderate pain, and they really form the cornerstone of management of pain after sports-related injuries, strains and sprains and the like. There's a group of atypical analgesics that work in different ways on different receptors, but have pretty good analgesic effects, and tramadol is one of those you might have heard about. Then there are neuropathic agents that work better for neuropathic pain, those nerve injury pains, than they do for acute pain, and gabapentin is the best known of those. Then we have an alternative group of drugs that we use in various ways, either topically or by injection. The local anesthetics, they actually work in a completely different way. They block sodium channels, and you get no conduction of the nerve traffic for a good long period of time, and we all know that. Lidocaine is the prototypic one now, but the one people know best is by its brand name Novocaine or Procaine. That's used by dentists early on. It's not used much anymore because of sensitivity reactions, and lidocaine is the more common one. It doesn't work for long periods of time, and it completely gets rid of all sensation, so it's very difficult to protect an area that's been anesthetized with a local anesthetic, and that limits their long-term use. And then finally, we're going to talk about opioid analgesics, which is where a lot of this controversy have come up, and the quintessential one, or the prototypic one, is morphine that people know best.
Neuropathic agents such as gabapentin, which would obviously fit in this category of neuropathic pain. Sorry. There we go. So neuropathic pain would get treated with gabapentin. And so the medical machine has tried to turn everything into neuropathic pain so they can add this drug. So, and I did say that the other day, they changed their models based on what drugs they want to use, when in fact they should be creating accurate models and then implementing accurate treatments based on those accurate models. The medical profession doesn't do that. They look at what drugs they have available, and then they look at the patient and say, well, we're going to make this drug fit your problem, even if it means we have to rewrite the science in order to justify this. That's exactly what they've done with fibromyalgia. And that's why the medical management of fibromyalgia includes neuropathic drugs, even though it's not a neuropathic disease. They looked hard and they looked everywhere to find any evidence in animal models, for example, of nerve injury in patients or models of fibromyalgia. They finally found it, and that now they get to use this class of drugs, even though it's irrelevant for the basic pathophysiology of fibromyalgia. The next group, local anesthetic agents like lidocaine. These act on ion channels, especially sodium channels, and then opioids, of course. So the political purpose of this presentation from Harvard Medical School appears to have been defending the use of opioids. I mean, that's all they did during the entire presentation. So again, and this is what we learned in medical school. That's why when I saw this list in this guy's presentation, I thought, wow, this wasn't just our medical school. This is really, apparently, the canonized medical model is acetaminophen, NSAIDs, atypical drugs, tramadol, neuropathic agents like gabapentin, local anesthetics, and opioids. I mean, when these people, medical pain specialists, when they think of pain, this is what they think of. And then, of course, you can go into more invasive procedures. Well, and sometimes those are good. You know, sometimes like nerve root blocks with anesthetics, or nerve root ablation, or surgery, or implanting devices, or cutting nerves, or amputating body parts for people who have really severe chronic pain. I mean, we can certainly go beyond this list. I don't know that most of us would want to, because they involve permanent surgical interventions or interventions with permanent consequences. Okay, so I did make some progress there. And just to be clear, what I want to state is that this model is not accurate. It's accurate, at best, it's accurate for acute pain, but it's not accurate for chronic pain. It's not accurate for, sorry, I have to, something about that wasn't quite right. It either wasn't right, what I just said either wasn't right, it's not the way that I want to say it, or it is right in the way that they say it. And that's probably where it is for me. The way that I just said that is correct based on the medical model, but it's not correct based on the way that I think it should be said. And I don't think I have to write that down right now, because I think it's going to become obvious in just a moment. But maybe I'll go ahead and write it down so I don't lose it. Okay, so I've talked about these two models. I talked about the little bit of comment about the Harvard Medical School presentation from 2018. And now I'm going to talk about these two articles. The second of the two articles, I'm only going to look over it really quickly. The first one may require a little more time, but I already reviewed it, so I don't really feel a need. I don't feel the need, and I'm not going to go through the article in much detail. That's a little bit of leftover water and honey from a previous beverage, which was coffee and protein. Okay, so let's see, where am I going with this right now? Oh, here's what I wanted to write down, and you'll see it represented in the title of this article. Remember, this exercise right now is pretty semantic. I acknowledge that. But it's not simply semantic. The medical mismanagement of chronic pain hinges on an error in logic, which I think I'm just now at the cusp of being able to decipher. And I think that this article exemplified that error. And that's where I'm going with this. So remember, we're talking about the medical mismanagement of chronic pain. Why does it persist? How did it happen? Why is it so powerful based on its persistence? How can this model of pain management be so ineffective and yet so stable? Like, why haven't they changed it? So where's the error that locks people into this model even though it doesn't work? That's the question that I'm trying to answer here. The medical management of chronic pain doesn't work for patients, and it doesn't work for doctors, and therefore it doesn't work for insurance companies either, third-party payers, governments. It doesn't work for anybody. The medical management of chronic pain doesn't work for anybody. Then why do we keep doing it this way? That's the question that I'm trying to answer, and that's the question that I think I now have an answer to. But remember, like I said before, the solutions to complex problems within a given discipline are usually not found within that discipline. So in this case, the discipline that provides the solution to this problem is psychology, but philosophy, and more specifically, probably analytic philosophy. Obviously not, I guess it could be more continental philosophy, but not like, Bertrand Russell style mathematical philosophy. Anyway, let's get back into this. Non-opioid pharmacologic treatments for chronic pain. So I'm not going to put words in their mouth or I'm not going to misrepresent what their position is. I'm going to read what their position is. And here's the mistake. It's actually in the first sentence of the article. So based on the way that I'm now understanding this, I think that the answer becomes more clear. Part of the problem is revealed in the title of the article, but also in the first sentence of the article. So the title is Non-Opioid Pharmacologic Treatments for Chronic Pain. I mean, it's an incomplete statement, but it goes back to the same problem. All right, so I'm going to highlight this. What key clinical issues? So here's how they're framing this, and here's how they're trying to orient the reader. In this case, doctors, practicing doctors, family medicine doctors specifically. Key clinical issue. What are the effects of non-opioid drugs on pain, function, and quality of life in patients with specific types of chronic pain? And what are the adverse effects related to those drugs? So let's see. Mostly, and maybe this is the point that I should have made at the beginning of this. I don't know, but we're getting there now. So let's just go with it. Here's the problem that I see, and here's what I've tried to understand and tried to articulate, and I've tried to understand it in a way that makes sense to me, but then also perhaps beyond a way that makes sense to me in a way that is clear and concrete and ultimately, I would hope, irrefutable. So let's just go with this. So here's the problem. We may have to go back to the treatments that were discussed in that presentation by Harvard. So let me pull up that article again. Sorry. When I edit this video, I'm going to have to blank out my screen so I don't show you this entire document, because this is a compilation document where I put a lot of ideas in there. But let's focus in on what the presenter gave us in the presentation from Harvard Medical School about pain management. Because this is the medical model. This is the medical paradigm. And we'll see it reflected back in the article from American Family Physician. Okay, so where am I going with this? Let's write it out. I'll write it out. Oh, I'm good to go. So here's the problem. How can a model, here it is, and maybe here's another way of articulating it. How can a model that is so successful for acute pain, why does that model fail so horribly with chronic pain? So here's where I haven't even typed this out in the new version of some of the pain management work that I'm developing. I'm on the cusp of typing this out, but I haven't typed it out yet. Let's see, where am I going with this right now? Acute pain. So here's what I'm going to type out when I type this out. Acute pain. Acute pain is not the same as chronic pain, where we would simply say, oh, well, chronic pain is the same thing. Chronic pain is not the same thing as acute pain. That's the problem here. What they've tried to do in the medical model is manage acute pain and chronic pain in the same way using the same drugs. But acute pain is not chronic pain. So acute pain, obviously short term. But that short term actually has many implications that go with it. So acute pain is by definition short term. Chronic pain is at least 3 to 6 months. Medical management of acute pain is, I don't know if I want to say it's fantastically wonderful, but it's pretty damn good. Whereas chronic pain management from the medical perspective is horrible. The treatments that are used for the management of chronic pain are the ones that I've discussed before: acetaminophen, NSAIDs, tramadol, neuropathic, the gabapentinoid type drugs, local anesthetics, wonderful, and opioids. Now, yeah, that's it. That's it. Because with opioids, you can sedate a person into unconsciousness, and they're not going to feel pain because they're unconscious. It doesn't mean, and I learned this actually from my first anatomy professor in 1992. He said basically this. He said, just because people aren't aware of feeling pain doesn't mean that the brain isn't receiving and recording that information. So that was interesting. And it's probably true. I suppose by now they have some evidence of that, or not, but they would have investigated it by now. But 30 years ago, it was just an interesting comment by an anatomy professor. Okay, so the mistake in the medical management of chronic pain is that what they try to do is they try to take a successful acute care model and turn it into a chronic care model simply by using lower doses or different combinations, etc. So what they try to do is they try to just move everything here over here. And it doesn't work. Okay. So let me be very clear on the fact that it doesn't work, because according to this article, they document and they prove that it doesn't work. The only thing that gets added, apparently, let's see, for chronic pain is they seem to add, I don't really know if that's perfectly true, but they seem to add anticonvulsants, and antidepressants. Keeping in mind, of course, that the anticonvulsant drugs actually work, but the antidepressant drugs are among the biggest colossal failures of the pharmaceutical industry's history. But because they're called antidepressants, people think that they function as antidepressants. Okay, so let's see, antidepressants. Specifically, we're talking about SSRIs or SNRIs, or combinations of selective serotonin and norepinephrine reuptake inhibitors. But basically, I was reading this article, last week in preparation for the video that I did last week on this article, and I was just like aghast the whole time. I'm like, this is a disaster. Going to definitions. Chronic pain is defined by these people as ongoing or recurrent pain that lasts beyond the usual course of acute illness or injury, or more than 3 to 6 months. Okay. But the part of this article that became most impressive is the fact that they have no big success with any of this. And so that goes back to the point that I'm making here, is that the categorization of acute pain and chronic pain, something is lost in translation here. If chronic pain were simply a prolongation, if chronic pain were simply a prolongation of acute pain, then the drugs that are so successful for acute pain should also work for chronic pain, but they don't. And that's exactly a major point that I've been perhaps trying to articulate. If this model were correct, let me change colors just so it stands out later. If this model were correct, so I'm going to call this, for the sake of speed, I'm going to call this A and B. If this model were correct, that chronic pain is simply an extension of acute pain, then A should equal B. So the distinction between acute pain and chronic pain cannot simply be duration. Because if that were true, then these drugs would be equally successful for chronic pain, and by their own admission, they're not. Not even close. Most of these are no evidence or very little benefit, even by their own, and I said this before, even by their own pharmacocentric biases, the drugs still don't work very well. So you've got small to moderate, no evidence, none. Chronic pain management from a medical model is a failure by their own admission. And the risks are outrageous, and the expense, any expense for a treatment that doesn't work is obviously too much expense. You'll remember the video that I did last week. I said, well, I'm going to highlight the ones that don't work. But as I started to highlight this chart, you can see that nothing works here. No evidence, no evidence, no evidence. Insufficient evidence, no evidence. None. You only get 1 dot out of 3. When they're talking about trying to improve short-term function, intermediate-term function, long-term function, short-term quality of life, or intermediate-term quality of life, virtually nothing works. I'll mention this one sentence that I talked about last week. NSAIDs exhibited moderate and short-term increases in serious gastrointestinal adverse effects. That was the whitewashing. That was a whitewashing event right there. They just whitewashed hundreds of thousands of deaths, injuries, and hospitalizations in that one sentence, because that's what they're talking about. They didn't even have the guts to talk about death. They just talk about serious gastrointestinal adverse effects. Well, come on, let's talk like adults. What are we talking about here? They're talking about gastrointestinal hemorrhage. People waking up in the middle of the night, throwing up blood, getting in an ambulance, going to the hospital, and hopefully usually living, depending on what country and what, environment they're in. But that was whitewashing. Hundreds of thousands of hospitalizations, injuries, and deaths. And they just call them serious gastrointestinal they just call them adverse events. Adverse events? Yeah, some of these drugs are known to be horrible, and some of these drugs are known to make pain worse. Opioids make pain worse in the long term. Okay, I'm finished with this article. What this article documented is the medical treatment of chronic pain using whatever drug is available, and it doesn't work. So that documents my concern that acute pain management, I think most of us who have had experience either as doctors or as patients, a lot of us would agree that acute pain management with drugs can be quite excellent. And this article documents that chronic pain management using the same drugs with a few more, which should therefore make it better, is a complete failure, mostly a complete failure for doctors and patients. So somehow we're making an error, we collectively, medically, we're making an error in assuming that chronic pain is simply an extension of acute pain. That's what I started to say a few minutes ago. I'm going to write it down right now. So the error is chronic pain is not an extension of acute pain. Acute pain isn't chronic pain. These are two radically different things. And what works very well for acute pain doesn't work at all, apparently, for chronic pain. So what are the differences then? So what are the differences? If saying that what I'm saying is that this isn't this, what are the distinctions? Well, again, what's obvious for me either is or isn't obvious for other people, but acute pain is obviously due to usually injury, whether it's trauma or surgery. It's mediated by neurotransmission, and peripheral pain amplification. You get it. Peripheral pain amplification. What's the mediator of that peripheral pain amplification? For me, obviously, for most of you, hopefully some of you it'll be obvious as well. The mediator of that peripheral pain amplification is prostaglandins. The emotional contribution is either minimal or actually helpful. Whoops. Because when people are, adrenalized and halfway in shock or whatever, that actually helps alleviate pain. So their emotional state actually helps to alleviate the pain. Obviously, depending on the level of trauma and the type of trauma, they can be in a lot of distress. But even sometimes that distress can distract them from the pain. So I'm just going to say the emotional contribution to amplifying the pain is actually quite low. At least that's what I'm going to state here. Peripheral pain amplification is mediated mostly by prostaglandins. Oh, the other thing, because we're talking about an acute setting here, we can use more toxic drugs. Okay to use drugs that are more toxic, like opioids. We can use drugs that are more sedating to the point of complete sedation, to the point of complete anesthesia. Oh, and the other thing is, people are usually in a supervised setting here. Supervision. They're hooked up to machines, they've got nurses watching them every few minutes, they've got doctors on call, etc. So we can take more risks. We can use different drugs, higher doses of those drugs in an acute setting, which obviously increases the probability of success. And we can't do that for chronic management because people can't or shouldn't or hopefully aren't on drugs that are highly toxic, highly sedating, and without supervision. So in the acute setting, we have more liberty to be more aggressive. We can be more aggressive. Whereas in chronic pain management, we can't be. But if the underlying physiology was the same, we should see, things be somewhat similar, if not identical, not necessarily identical. Anyway, what are the distinctions with chronic pain here? Oh, let's see. Going back to the emotional contribution, I'm going to say minimal, possibly helpful at times through distraction or adrenaline. But the other thing is, whether it's trauma, except for right when the trauma happens, but let's say a day or two after the trauma, or the day or two after the surgery, or the surgery was planned, people know that it's going to be short term. They have an accident, they might be broken up, they might be injured, they might be hurting, they might be crying. But on some level, they know that in 2 or 3 days, whether they say it or not, whether the doctors say it or not, everybody knows in 2 or 3 days they're going to be out of pain. They're going to be a lot better, even if they're got broken bones and cuts and whatever else. The brain hasn't been rewired to the situation because the situation has been very short term. So just like with surgery, when people go through surgery, even if it's a major surgery, they know, and the doctors know, and the nurses know that they're going to, it has a limited duration. They're going to heal. The wounds will close. Problems, especially in the acute setting, in an inpatient setting, can be managed. So I'm going to have to say it's that acute pain, even though it might hurt badly at the moment, I'm going to say that it's not as distressing. Or maybe I want to say that slightly differently. Let me just say it that way. I'll put a question mark there. But what I really mean by that is that the brain hasn't been rewired. No brain CNS rewiring. Now, in contrast, chronic pain, remember, they've been saying that these things are equivalent when they don't feel, function, or respond in an equivalent manner. So obviously a problem has existed here. My argument is that chronic pain is not an extension of acute pain. Chronic pain is usually the result of a disease process, which is probably, the disease process itself is actually remarkably indifferent to pain, but only causes a pain that's secondary. With injury, trauma, surgery, the pain is primary to that event. With chronic pain, the pain is secondary to a disease process which only happens to produce pain. Sure, with chronic pain, we've got a neurotransmission component. So I'm going to put NT for neurotransmission or neurotransmitters. In some, but not all, chronic pain conditions, we have a prostaglandin component, which would justify, therefore, the use of NSAIDs or botanicals. So I'm going to put PG. I'll put PG/NSAIDs. But that's it. The pain in so-called chronic pain conditions includes, in a way that we don't see with acute, I mean, we can look for it in animal studies. If we look hard enough, we can find some of this stuff. But I'm talking about in the big picture, in a clinically meaningful way, we either don't see it or we don't see as much. Spinal cord remodeling. I'm just going to say CNS. I'm going to say brain and spinal cord remodeling. I'm going to say central nervous system, CNS, remodeling, or rewiring. Because in chronic pain, the pain amplification isn't peripheral. but is due to rewiring in the spinal cord and brain, and also pain and amplification due to neuroinflammation. Neuroinflammation. Astrocytes, microglia, other immune cells, cytokines, and the changes induced by cytokines on neurotransmitters, which are not, in a way that's not touched by so-called antidepressant drugs. So I'm going to put neurotransmission or neurotransmitters not touched by antidepressants as commonly used, especially SSRI, which I think those are probably among the most worthless drugs ever developed, and SNRI, which I have more sympathy for those drugs. Emotional distress is a bigger issue with chronic pain. Distress in a way that involves what did I say before? Rewiring or remodeling. Those are true. But, so let me just write that. Distress with chronic disease leads to rewiring. But it also leads to neuroinflammation. As I mentioned here, which involves astrocytes, microglia, etc. So a distinction here is that we're starting in the cytokines as well. A distinction here is that we're starting to see, I haven't written them all out, but they're still here. We're starting to see a vicious cycle here. Distress causes neuroinflammation that leads to changes in cytokines and therefore neurotransmitters, and so does the disease process itself. So we're starting to see vicious cycles and reinforcing cycles with chronic pain that we don't see with acute pain, therefore further supporting the fact that A isn't B. Oh, well, and obviously with chronic unable to employ, we can't use highly toxic drugs in the chronic setting that we could use in the short-term setting. We can't use sedating drugs, and we don't have supervision, which means we can't use certain combinations, higher doses, more risky procedures, etc., because people have to be able to function on their own. Some people live alone. Even if they don't live alone, they probably drive alone, and so they can't be at risk for, losing consciousness while they're driving or etc., even being drowsy. The other, so those are just some of the, those are what occurred to me as some of the more superficial details, I suppose. If we were to then apply my anti-inflammatory, inflammation mastery, functional inflammology model to this, we would see that those things become relevant. Those things become relevant in chronic pain in a way that they don't in acute pain. So, for example, in most conditions that contribute to so-called chronic pain, we see a dietary component. Diet and food becomes more important. We see a bigger role for dysbiosis and chronic infections. The immune system, as I already said, becomes more involved, at least within the brain and spinal cord, as neuroinflammation gains momentum. We see metabolic and mitochondrial problems. As I said before, stress becomes a bigger issue. Well, I guess both of these have stress, but again, if someone has an acute injury or they go through a planned surgery, then they know it'll be rough for a few days, but it's going to be better. People with chronic disease don't have that. They don't have that optimistic outlook. They don't get to say, wow, this is going to be better in a week. Or, man, as soon as those drugs kick in, I'm going to be out of pain. They don't have the ability to say that. These people also tend to have hormonal problems. And sometimes, depending on which disease we're talking about, they may have a xenobiotic component. So, you're about to have a pop quiz. So, the pop quiz for all of you is that if you consider yourself familiar with my work, then you know what I just did right here. If you consider yourself familiar with my work on a basic, intermediate, advanced, intermediate, I guess. If you consider yourself familiar with my work on an intermediate level at least, then you know what I just did. You know what I just outlined. Right? So this is just a pop quiz. I don't want to make this too much of a distraction, but I would like for everybody who's watching this to be familiar with the work that I've done. And if you are familiar with the work that I've done if you've seen one video, then I guess you're at a beginner level. But if you think that you know my work, I guess at a kind of an intermediate level, I don't know if it would really be, at least at the intermediate level, you would have to know what I just did. You would have to know that these are the 7 components of my functional inflammology protocol. I've been talking about this for 12 years or something like that when I first published the work. Yeah, it was back in 2012. Actually, it was March of 2012. I remember exactly. I was in Paris the first time that I published this. So this was from the 2012, and I don't expect everybody to know this, presentation in Paris, France. This is my functional inflammology protocol. Which I originally trademarked in 2012. and have renewed the trademark since then. And so this is it. This is what I just talked about right here. Let me see if I can find a different marker for that. Yeah, I'm just going to write it with different letters. Even though I don't really like these letters. I don't like this marker very well. But this is F. Food, chronic infections, nutritional immunomodulation, dysmetabolism or dysfunctional mitochondria, FIND, stress, endocrine disturbances, and xenobiotics or toxins. So this is FIND, find SEX. So for the at least intermediate and advanced students who I've either had in class or you've read my books, you should know that this is what I'm talking about. These are the things that we see in chronic pain conditions and which we can address, which we don't see in acute pain. You don't see these contributions in acute pain. Maybe a little, very little, but they are the major pillars of maintaining chronic disease states. Okay, so I'm going to say that we're finished with this article here. Oh, I just saved it. That's fine. Let's go to this article because I said I would talk about this. I'm just going to look at this very quickly. This was a painful article. All they did was talk about exercise. Let's see if I can highlight this. So they call this key recommendations for practice. So what did they talk about? They talked about exercise. They said basically do whatever you want. Low impact yoga. Cognitive behavioral therapy. Mindfulness. I could care less about mindfulness, believe me. Spinal manipulation, fine and good. Acupuncture, massage, myofascial release. Multi or interdisciplinary rehabilitation. They didn't even talk about what it is. They also talked about like low-level laser and things like that here. So, potential components of a multimodal pain treatment plan. Psychological approaches. Progressive muscle relaxation. Sorry, but I don't think I have time for that. Occupational therapy. Health therapies. What's a health therapy? They're trying to make this sound like a vitamin shop, basically. Spinal manipulation, acupuncture, yoga, massage, electromyography, feedback. Some of these things work, but it's still, this is weak sauce overall. Stretching, walking, strengthening, Tai Chi, Qigong. Healthy eating. Hey, there's a great idea. Healthy eating. Let's go out and do some healthy eating. Weight management, heat, ice. So that's why I told you before, like this article is just fluff. Most of it's just fluff. No mention of nutrition here, other than quote unquote healthy eating. These are all beneficial, but they're not going to change the course of the disease. And that's what we commonly see in articles written by and written for medical doctors is when they talk about non-drug options, they just talk about these fluffy options that have no chance of curing the problem. And that's why they talk about them, because they have no chance of curing the problem. So if you look at my work, Inflammation Mastery, 4th edition, chapter 4, which starts on page 330, you'll see that I detail the functional inflammology protocol, the 7 major modifiable factors in systemic inflammation, allergy, autoimmunity. And when I finish writing chapter 6, then of course I'll talk about chronic pain specifically. But here's what I just talked about: food, infections, nutritional modulation of immune function, dysmetabolism and dysfunctional organelles, especially mitochondria, stress, sleep deprivation, spinal health, social and psychological considerations, endocrine imbalances, and xenobiotic immunotoxicity. And here's what it looks like in the diagram that's on the cover of the book. All of these feed into immune activation. We could also say chronic pain. Then we get the elaboration of these inflammatory mediators, changes in gene expression, etc. And that's what leads to clinical manifestations. So this is basically a model also of chronic pain. Immune activation, degenerative changes, etc. Changes in immune nervous systems, hypersensitivity to pain, basically. So what I said previously in the context of treating inflammatory disease also applies to chronic pain. Obviously, here I quoted Nietzsche, so we'll look at a little bit of Nietzsche, and I'll try to wrap this up within the next 15 minutes. The first quote is really nice. You can pause the video and read that first quote right here. It's quite pleasant. This second quote: in order for a particular species to maintain itself and to increase its power, its conception of reality must comprehend enough of the calculable and constant for it to base a scheme of behavior on it. Obviously, or perhaps not obviously, but that's one of my favorite quotes from Nietzsche. As I mentioned before, 2012 in Paris was the first time that I presented this in this way. And from that time forward, I copyrighted it, trademarked it, protected it, and have described it in the videos that you have available to you. So those videos are available at my websites, inflammationmastery.com, and also my blog, which is healthythinking.substack.com. So if this is not familiar to you and you want to understand chronic disease management, then I encourage you to look at those videos and obviously the protocols that are in the book. So that's detailed in the textbook, Inflammation Mastery, 4th edition. So ultimately, by now, what I think you can appreciate in what I said is that the medical profession tries to pretend that the medical profession tries to pretend that A equals B, but their treatments don't support that. If A equaled B, then the treatments for A should reach the same level of effectiveness, or at least close to what we see with B, and they're not even close. Acute medical pain management is awesome. Chronic medical pain management is a disastrous failure. But they keep doing it. So this is what we call a category mistake. In psychology, but especially philosophy, the language is category mistake. Now, I don't have all my books with me. They're still in the process of getting relocated. But Nietzsche talks a little bit. This is a Nietzsche reader, which hopefully you read this in college. If you haven't read it by now, then you should read it if you want to understand philosophy, etc. A reasonable core book would be the Nietzsche Reader. And of course, you can buy a legit philosophy textbook. This textbook, to my shock and dismay, didn't even talk about category errors, which is what I'm talking about here. So, this entire medical mismanagement of chronic pain is a category error. So, let's go back to black ink and we'll talk about category errors. Actually, we talk about something else. Category error versus a category mistake. So in philosophy books and in logic books and videos, which we're about to look at, this is commonly described, I'm sorry, let me say that slightly differently. This dynamic that we're talking about is commonly described as a category error or a category mistake. But actually, errors and mistakes are not the same. So I suppose that's an irony. That's an irony. In the conversation of category errors, which are also called category mistakes, the language that we're using here is its own category error and category mistake. Because we're kind of assuming that errors are the same thing as mistakes, and they're not. So errors are typically described as being a result of improper thinking. Like you just don't know, or you don't understand. A person just doesn't have the data, or they don't understand the data that they have. So this is bad thinking. Errors are the result of bad thinking. Mistakes are the result of being a human being, or just what I consider to be bad processing. So a mistake is made when somebody knows how to do something right and they screw up. They push the wrong button. They say the wrong word. They know what's right and wrong, but they made a little mistake, temporary, and they can self-correct. The problem with erroneous thinking is that people can't self-correct. Oh, I'm sorry. They can self-correct. So I'll turn that into a check mark. They can self-correct. With errors, people don't self-correct. Because they don't understand what they don't understand, and that's where the problem is. So there's no self-correction with an error, whereas with a mistake, people can say, oh, well, I screwed up. I said the wrong thing. Of course, I didn't mean to say cat when I should have said dog. But because errors are due to errors in thinking, people may not have the ability to self-correct. So this gets back to what I've talked about before, Dunning-Kruger. That's a different essay. I've talked about that on the blog. You can take a look at it. So we're going to call this a category error or a category mistake. It's in a sense, it's kind of both. It starts out as a category mistake, like, hey, we're just differentiating time duration. We're just differentiating acute versus 3 to 6 months. But it becomes a category error through the lack of analysis of the distinction between the two types of pain, which I just described above. So the medical world, they start by distinguishing acute pain from chronic pain by talking about duration. So that's some type of reasonable mistake. So the way that I want to say this, or the way that I'm going to say this, is that maybe this whole thing started innocently by looking at things as they appear. Well, one is short-term and one is long-term. Let's call one acute and the other one chronic. But it becomes an error in thinking when one engages in at least some superficial level of analysis. I mean, look at the differences between acute pain and chronic pain. So it starts out as a mistake and then becomes an error. So I'm hoping that all my devices keep recording for a few more minutes, because I realize some of these devices are on low charge or they didn't have a lot of space. So I'm obligated to wrap this up at some point for the sake of technical limitations, because this machine had a low battery and somewhat low space that's going to run out eventually. So like I said, I have to wrap this up. Otherwise, machines are going to start crashing. So again, as you can see, according to this article, the article that I looked up, I didn't get a lot out of this article. The persistence of category mistakes in psychology. The term category mistake apparently was popularized by a philosopher, Gilbert Ryle, in a book called The Concept of Mind, which I haven't read. But he does say something interesting here, which I think applies to the medical mismanagement of chronic pain. He describes a family of radical category mistakes as the source of official doctrine. So I think that we see the same thing in medicine. What we see in the medical management of chronic pain is a family of radical category mistakes that have become the official doctrine. The official doctrine, which we all admit doesn't work. Let me see if I highlighted anything else. I might not have. Oh, well, yeah. So the reason I didn't highlight anything else is because I read this on my phone. And I don't have a program on my phone that lets me highlight. Let's see. So we looked at this. Okay, so I think we're at a point now where I've talked about what a category mistake is. In this case, I think that what we're looking at is how a category mistake became a category error based on the way that I described that. So what started out as maybe somewhat reasonable back in whenever this was developed, let's categorize pain as either acute or 3 to 6 months, has now become, I believe, an error. Because it's driving bad thinking, not simply resulting from bad thinking. Maybe that's a good way for me to say this. An innocent mistake in categorization can become a horrific error when it becomes codified or made official. Official. When it becomes or codified, official, standardized, unquestioned, an innocent mistake in categorization can become an error which drives bad thinking, which now drives bad thinking to become permanent. Sorry, I'll go back and erase that. Now drives bad thinking to become permanently flawed. There it is. This is a category mistake that now is a category error. An innocent mistake in categorization can become a horrific error which now drives bad thinking to become permanently flawed as it became codified, official, standardized, and unquestioned. I think that's what happened. I think that is what is continuing to happen. I think that explains the failure of the medical management of chronic pain. But I'm going to take it one step farther, and hopefully this will wrap this up. Because I want to include something I just saw last night that I mentioned previously. So, let's see. We'll go with a dark green, or maybe a brown. Let's go with brown. So here we have a category mistake that has now become a permanent error, which is driving bad thinking and bad acting, bad behavior. Otherwise known as, e.g., the medical mismanagement of pain. And again, if people get relief from pain through medical treatment, more power to you. And of course, I don't want to see anybody suffer unnecessarily. But the global overall consensus is that medical management of chronic pain is a disaster. A lot of it doesn't work. They have to do tons of stuff together that doesn't work. It's very expensive. Sometimes it causes permanent nerve injury because what could be a more horrific solution, quote unquote solution to chronic pain transmitted by nerves than destroying the nerves themselves? So one of the medical treatments for chronic pain is nerve ablation, burning out the nerves so they can't transmit anymore, and sometimes that causes its own pain. So this was I think, an important revelation. But what I also wanted to add, for the sake of completeness, and this will bring this video to a close, is that category errors and category mistakes don't have to just sit disconnected from the rest of the world in a way that leaves their evaluation and their value to be subjective. So, for example, in this case, I'm saying that the medical mismanagement of pain is a category error and a category mistake. I'm saying that it is that, and I'm saying that that explains its well-documented failure. I mean, if you look at spinal surgery for pain, it's a disaster. It's called failed back syndrome. If you look at surgery for meniscus tears and osteoarthritis of the knee, it's a horrible failure. So sure, we can find exceptions and we can find people who have benefited, and I'm happy for them. But generally speaking, for example, surgery for osteoarthritis of the knee for at least 20 years, pretty much 20 years now, is noted to be horribly ineffective. So I'm stating that this is established and that it represents a category error. But like I started to say right now, the evidence proves that I'm correct on that, I believe. And so, again, what I was just reviewing right now is all you have to do is look at the consequences. If it weren't a category mistake, then it wouldn't have the horrible negative consequences that we see. Beyond that, at least, and maybe this could be considered within consequences, but teleologically, if we look at the far term, not just the short term, but the far term, not just the near term outcomes. So this is part of consequences. So we could say short term or longer term, a more teleologic, but I don't want to just look at like clinical outcomes. I would want to look at societal outcomes as well. Short term, long term, but even bigger, social, etc. If we look at that, if we look at everything that I've talked about here, which I'm calling a category mistake when I discuss medical pain management, someone could say to me, well, that's just your opinion. To which I would respond, no. Supporting what you call my opinion is reality, showing these massive negative consequences, both in the short term and in the long term. So, something about what I'm saying here is right, and I'm describing it in philosophical terms as a category mistake and a category error. So the mistake being made is the assumption that chronic pain is simply an extension of acute pain. I'm trying to see if I wrote that down somewhere. Yeah, so the error is chronic pain is not an extension of acute pain. Because if that model were correct, that A equals B, just with more time, then the treatments for A should be equivalent in effectiveness to the treatments for B, with a few exceptions. But it's nowhere near close. So I'm going to try to add, assuming that my machines continue working here, I'm going to try to add a quick video clip from something that I saw last night, which helped me take this step. Hold on a second. I'm going to change colors. So I was already on the trail of calling this, of course, a category error or a category mistake. Or in this case, like I described above, I think it perhaps was a mistake that then became an error in the way that I described the difference there. Again, a mistake is, well, you thought of something really quickly without thinking it out, and that's what they did. But then that mistake is now driving a paradigm of thought that people can't escape from. So this is where I have been for the past 3 days. I was here in everything that I just discussed. The change that occurred for me last night, and I've thought about this before in a different context. I have to go back and look through my own documents and my own notes, because I did about 10 years ago. I was really captivated by this concept, and so I have to go back and see what I did with it. Maybe I didn't do anything with it. So I was a little bit surprised to see it come back to me in this context. But I'm going to show you a quick video clip right now that discusses the change that occurred to me last night, going from category errors to category mistakes. It's a very subjective distinction. Oh, no, here's what it was. The word isn't consequences. At least not the way that it was used last night. The word that was used last night is context. But the way that I interpreted the his use of the word context was to look at the consequences. So I'm just going to say one more thing, and then I'll show you this video clip. For example, from a purely philosophical standpoint, when we talk about category errors or category mistakes, they of course use, people who are more philosophical than I am, they use certain examples. But for example, most of us would agree that a wrench or a watch, obviously those are different, but let's just say a mechanical object made out of steel. We would say that a watch is not the same thing as an orange. And if you try to put those things in the same category, you would be making a category mistake. But the fact is, depending on the context, a watch and an orange could be in the same category, right? So a watch is made out of steel. It tells time. It's expensive, usually, sometimes, depending. Not all of them. Sometimes it's considered to be kind of a rich thing because it's kind of decorative. What else? Those are some basic descriptions of a watch. It's mechanical. Somebody had to make it. Whereas an orange is just a piece of fruit. And it's soft. And it's organic. So, like if you were to study category errors and category mistakes at a very basic undergraduate philosophical level, you could use this as an example of a category error. You can't put watch and orange in the same category. So a category error is putting two things in the same category that don't belong together, or separating two things that actually do belong together. But a category mistake or a category error can't be claimed without context. And this is what I learned from the video last night. Because in a certain context, a watch and an orange could be in the same category. because they could both be used as gifts. They're both small handheld objects. And if you're in an argument or you have to defend yourself from someone, you could use them as a weapon. You could throw an orange and try to hit somebody in the face. Same thing with your watch. Let's assume it's a metal watch and you've got nothing else. You don't even have keys or anything else to defend yourself. You could try to use your watch as a weapon, either throwing it at someone's face or trying to scratch them with it. You wouldn't have as much success scratching somebody with an orange, but you could still throw it and try to hit them and distract them or injure them in some way and get away. So a watch and an orange could be used as a gift. They're both small handheld items, and they could both be used as a weapon. And they both cost money. So depending on the context is ultimately what defines whether or not a category error has occurred. That's what I learned from the video last night. And I'll show you 30 seconds of that video, just to give him credit, but to also show you that I'm not the only one who thinks about these things, maybe, I guess. So the consequences are part of the context, which helps us validate whether or not a category error or a category mistake has been made. Let's take a look at that clip. You can pause the video if you want to read this. This is from Nietzsche's Will to Power. It happens to be a quote that discusses human perception of knowledge. I don't think I'll take the time to read it right now. Let me see. I had another one. Yeah, same thing here. These are just quotes from Nietzsche about, again, human perception of knowledge. These are both from The Will to Power, which was a book that he never published. It was published by his sister. Let's see if we can get this video to play very quickly. Because again, this is the video that I saw last night.
Hello. One of the commonest errors that people commit when discussing various philosophical, cultural, and social issues with one another is the category error. The notion of a category error is extremely important in philosophy, which is why already Aristotle made sure to discuss it in his aptly named categories. By saying Socrates, I refer to Socrates. When I say Socrates is a man, I introduce a category, man, that includes items that are not Socrates. So how do those items help me understand the first item, Socrates? Understanding categories helps us understand reality, the objects with which we interact, and the situations in which we find ourselves.
So that was a really great introduction to categories. He very briefly there gave some history, where it came from. It came from Aristotle. And then he also, I'm going to post this video, I'm going to post a link to this video when I post this video review that I've now spent 2 hours on. So he talks a little bit, I'm just reading his headlines. He talks about Socrates, category errors. He talks about that book that I mentioned previously. But here, at approximately 3 minutes and 15 seconds into this video, is where he mentions that categories have to be evaluated within a context. And for me, that provided me a bit of a nudge or a push into a deeper understanding of this entire topic, which is why we have the video that we have right now. So let's see. He's giving an analogy here, and then he jumps into the part that for me had value. So this is the part that helped me get a better understanding of the objectivity of categories, because if we don't provide a context to the category, then it could either be right or wrong, or it could be right in some situations and not others. But we have to look at the context and the consequences short-term and long-term. And that's what I got out of this clip when I was trying to understand this better. So let's let this play for about 5 or 10 seconds.
Now, one must be careful because it is possible to categorize things in different but equally valid ways depending on the context. It would not be unreasonable to say that politics and art are two different categories in many contexts.
So that was it. That was it right there. 6 seconds, or maybe it was 9 seconds, sorry. But that's the part that helped me understand this better.
Now, one must be careful because it is possible to categorize things in different but equally valid ways depending on the context.
So the context is what determines the validity of the categorization, therefore determining if it was appropriate or if it was a mistake or an error. So again, clinically in medicine, what is the context? The context is the application and efficacy. Did it work or not? If it worked, that proves that you were on the right track. If it didn't work, that proves you're on the wrong track. If you're spending billions of dollars to get negligible results in chronic pain management, then the context and the consequence is proving that someone made a category error. This is one way of looking at it, among other ways of looking at it, but this is still valid. The negative outcomes are proving that an error has been made. And I think I have defined and described now the error that's has been made. And let's give our fellow medical doctors the benefit of the doubt. Let's assume that this started as a category mistake, which then became a category error, driving bad thinking. So what started out as just a categorization based on convenience and description is now driving bad thinking. Because the bad thinking that's being driven is that acute and chronic are the same, just one is longer than the other. And that's nowhere near the truth, as I described here. And more specifically, the treatments of which I described 12 years ago when I first published Functional Inflammology and discussed this Find Sex protocol, which I call the Functional Inflammology protocol. So that's been my effort to decipher how can the medical world continue to mismanage pain when they themselves acknowledge that the results are horrible, but they keep doing the same thing over and over again. So something is driving bad thinking. Not simply profit motive, not necessarily simply the fact that these are the drugs they know and the drugs they sell, and the fact that the treatment fails actually benefits them because then they get more return visits and they get to bill more and they get to do more procedures, and those of course are more profitable than simply prescribing drugs. So yeah, it is a vicious cycle, but on some level it's not simply a vicious cycle of behavior, it's a vicious cycle of thinking, or in this case thinking incorrectly. And so what I've been trying to do lately, and perhaps what I have achieved now, is an understanding of how this started and why it perpetuates itself, and also validating that it's occurring. And the validation comes from the context, which includes the consequences, which we're all aware of. We all know that medical management of chronic pain is a failure. For the most part, it's a failure. Multi-million dollar, multi-billion dollar failure. But so why does it keep happening? And that's because the people who are indoctrinated into this paradigm, they're trapped into this paradigm. They can't see a way out of it. And the medical journals like American Family Physician, but even the specialty journals like Mayo Clinic Proceedings, New England Journal of Medicine, Nature Reviews Rheumatology, where I published an article on chronic pain back in 2016. They're trapped, those people on that side in the medical indoctrination world, they're trapped here on this page that we're looking at right here. They're trapped trying to convince themselves that chronic pain is simply an extension of acute pain. That's where I wanted to go with this, and I think that I've described it and explained it now sufficiently. I told you this was going to be painful. I told you it was going to be spontaneous. I had a lot of distractions over the last few days, but that also bought me time to subconsciously work on this. And thanks to being so exhausted last night, I watched a few more videos on category mistakes and category errors, and that's when I found this video, which helped me solidify the components of this idea, and that is a category error is only such when it, within a certain context, which has to include the consequences of the idea. If the idea was correct and beneficial to life, if the idea was correct and beneficial to life, then it should be consistent with the advancement of life and therefore useful. But if the idea is incorrect, then we're going to find it to be harmful to life. In a medical context, we call that pain, suffering, inefficacy, and expense, and disability. And those are and addiction. Those are the consequences of the medical management of chronic pain. Inefficacy, failure, ongoing pain, disability, consequences from treatment, consequences from surgery when the drugs don't work, massive expense and inefficacy and wasted time and effort for the doctors, but also obviously wasted time and effort and expense for the patients. So looking at the context, which includes the consequences, that helps to prove that something's not right here. I'm describing that something that's not being right as a category error, an error in thinking, which is perpetuating this problem even in the face of massive failure. So I think I said pretty much everything I want to say. I'm going to close out this video. We're at 2 hours and 10 minutes. If you need me to repeat any of that, just watch the video again and leave a comment in the discussions, and we'll take it to the next level. And maybe make some changes and some modifications. But like I said at the start of this, even though I hadn't gone through this, obviously, to polish it, I knew that I was going to be within 90% of what I wanted to say, and I'm probably more like 98% of what I wanted to say. So I think that for now this is sufficient. I'll close this out. I'll get it edited. I'll post it tomorrow, or maybe tonight, depending. With 3 different video files, this thing's going to take forever to process, let alone edit. So I'm going to leave that here. And I'll close this out and I'll review it, and then I'll probably review it again and make maybe a shorter, polished version. I think I'll do that at some point. But that's kind of where I am. This has been the result of a lot of days of trying to understand, like I showed you in those articles. I mean, even looking at articles in computer science and trying to understand what is perception, to then understand, perception, ideation, conceptualization, judgment, and then action. Something's broken in that chain of events in the medical management of chronic pain, and I've been trying to understand what that is, and maybe now I have it here. So again, I'm going to close this out and call that good enough for this evening. Hope you're all doing well. I'll get this posted on the websites, my two main websites, hopefully now and forever, will be inflammationmastery.com and healthythinking.substack.com. Thank you very much. This has been Dr. Alex Vasquez coming to you live in January of 2024. Thank you. Hello everybody, Dr. Alex Vasquez here. Sometime in the middle of January of 2024, I'm actually editing the spontaneous video that I recorded, I believe it was Monday or Tuesday. So this is going to be a spontaneous video on top of that spontaneous video. So I recorded a spontaneous video of about 2 hours, and then I edited it. I finished editing it yesterday, and now I'm editing it again. And in the process of editing it again, of course, I'm discovering some new insights and new opportunities to explain what the hell it is I'm talking about.
It's very hard to find your own words, but you don't actually exist until you have your own words.
So just now, while I just now finished editing the first 30 minutes between last night and today. And when I reached the end of that first 30 minutes of that 2-hour video, I realized what I was talking about.
It's very hard to find your own words, but you don't actually exist until you have your own words. So then you try to teach yourself how to speak your own truth, and you listen to other people while you're doing that because they can help you shape and correct your words. They'll react to them badly if you formulate your ideas badly, and if you listen and pay attention, then you can learn to formulate your words more and more clearly and accurately, and that makes you more and more powerful. It gives you more and more authority, which is the beneficial form of power.
And so I'm going to explain that right now. I'm going to explain what I consider to be the first 3 sections of that video. I'm going to explain that right now just to help people orient to the material. So, as I've said before, the topic is medical mismanagement of chronic pain. That's the topic. So in the first 15 minutes, is that correct? Yeah, I'm dividing this into 15-minute segments for the sake of making progress in a stepwise manner for one, but also being able to upload these videos to a new YouTube channel that I created because all my other YouTube channels are blocked. So they limit me to 15 minutes. So that's okay. I'm just trying to do this in 15-minute chunks. So I did 15 minutes last night, and then I was working on 15 minutes this morning. And then I stepped away from it for a few minutes, and then I realized exactly what it is I was specifically stating. And so I want to articulate that right now very quickly, of course, as quickly as I can, just to help orient people to the material. So we could say that the first 15 minutes, I'm basically just introducing the topic and trying to get oriented because, like I said before, it was spontaneous. So the first 15 minutes, I'm kind of orienting to the problem of what I consider to be the medical mismanagement of chronic pain. And I'm basically I'm introducing the questions that I'm going to ask, those generally being, what the hell is going on here? So that's a little bit crude, perhaps, but that's the way that I perceive it, even though I didn't state it as such. But I was basically introducing the question, why does the medical profession mismanage chronic pain? They readily acknowledge, if you look at the review articles, etc., and if you look at the expenses, I mean, the expenses of pain management, or the expenses of pain management are greater than all of the other major diseases. So let me pull up that quote very quickly here. I put it in the video yesterday. Of course, this program can't simply give me what I want. I have to dig and dig for a minute, even though I was just here yesterday. Pain costs in 2011. Conclusion of this book, it was actually a book that was published on the economy of healthcare expenses. The conclusion from this book, published in 2011 in the United States, we found that the annual cost of pain was greater than the annual costs in 2010 US dollars for heart disease, cancer, and diabetes, and nearly 30% higher than the combined cost of cancer and diabetes. That's amazing. The total financial cost of pain to society, which combines the healthcare estimates and the 3 productivity estimates, ranges from $560 to $635 billion in 2010 dollars. Again, the final phrase of the concluding sentence: the annual cost of pain is nearly 30% greater than the combined cost of cancer and diabetes. That's just amazing. So the outcomes of the medical management of what we could call either chronic pain or chronic pain conditions or chronic conditions that result in pain, all of those are very different. The combined costs are enormous and the outcomes are pathetic. They're horrible. A lot of the medical interventions are no better than placebo, and we've known that for decades, and nothing changes. So, for example, I remember back in 2006 when I was doing certain presentations related to integrating nutrition into clinical practice. I remember then I used the example of how arthroscopic surgery for osteoarthritis of the knee had been shown to be no better than a sham procedure. That was so I was lecturing on that back in 2005, 2006. That line of research has been replicated numerous times, but they still keep doing the same thing. They've proven in the research, I believe most of these articles have been published in the New England Journal of Medicine. So no one can say they didn't know about it or it was a super specialty journal over here that no one read. No, it was in the New England Journal of Medicine, and that was recycled in the New York Times, etc. So we know that medical pain management is outrageously expensive and outrageously ineffective. So ineffective that it's equivalent at many times, to doing nothing. And so why do we keep doing it? That's the question that's the question that I'm addressing in this 2-hour video. So I introduce that topic in the first 15 minutes, and I'm basically saying, what the hell are we doing here? That's the intro of the first 15 minutes. Then the second 15 minutes has two sections in it, which perfectly end at the 30-minute mark, thankfully, because I just now finished editing that this morning. And the questions that or the issues and questions that I address in the second 15 minutes are event model processing, or let me see exactly how they state it, because I do reference a few articles. So I look at one article from Trends in Cognitive Sciences, Constructing Experience, Event Models from Perception to Action. And the comment that I make based on a review of this article, which was a bit of a tangent, but it actually turned out to be important. So in the second of the 15 minutes of this video, I go on a few tangents, but those tangents actually ended up being perhaps perfect for the conversation. So the second topic, or tangent perhaps, was event models. Because as I stated early in the video, the rather abstract question that I'm trying to address here, even though I'm trying to ultimately end up with concrete actionable data, of course, that we can use in pain management, the first level of approximation has to be trying to understand exactly how we as human beings understand reality. And so that's why I looked at some of these articles from Trends in Cognitive Sciences, the construction of experience. How do we construct our experience? Event models from perception to action. And I commented in reviewing this article briefly in the video. They talk about event models from perception to action. And I commented that they skipped something here, right? So they went from perception to action, but they skipped something in the middle. This turned out to be an important article, especially when we reference it with a different article. Let me look at the other article. I'm looking at one article right now, but that's not the article. So I have to go to the other one that I reference in the video. This article from Frontiers in Neurorobotics was published in October of 2020. Perception, Understanding, Action. Oh, this is good. This is good. So, as I point out in the second chunk of 15 minutes in the video, what's missing in the event model that was presented in the other article, what's missing was the intermediate step of understanding. So I'll change colors just to make it stand out. So then, the third part, and then I'll go back to the second that I'm mentioning right now. The third part that I get into is another tangent, talking about education. And specifically, I get into this model of education that I don't like, called Bloom's taxonomy. So this is a very dominant model in education. Commonly, it's represented as a pyramid, as I showed in the video. And the bottom of the pyramid, the most basic level of education, is just memorization. And the highest level is synthesis and application and understanding. Let me see if I can see it real quick. Let's see exactly. Right. So Bloom's taxonomy, the model that's shaped as a pyramid, has been revised at least once. And according to the one that I'm looking at right now that's in the video, the top of their pyramid is creation, evaluation, and analysis. And apply is actually in the middle. So they just say create, evaluate, and create. So I've hated this model for literally decades, but exactly right now I think I understand why at a deeper level. Evaluate and create is what they say. So I come in with fire and brimstone and say that model is a poor model of education, because the ultimate goal of education should be to empower students, people, professionals to predict the future. And not just in some weird esoteric way that we usually would think of prediction, but based on pattern recognition. So, I mean, it's a completely logical extension of the educational model that going through education, we would learn enough data to recognize patterns that we could anticipate in the future, even before they've played out. So, for example, if you look at just as an example, if you look at the article that I wrote in 2004 on vitamin D, it was called the Paradigm Shift in the Clinical Use of Vitamin D. That was a descriptive article, but it was also predictive, quite accurately, I might add. So I wrote that article 20 years ago, and it's been perfectly consistent with what we've seen in the related research now for 20 years. So prediction, something that's missing from formal education, is a focus and application and exercise in predictive ability based on pattern recognition. So prediction, pattern recognition. Predictions based on pattern recognition should be expected to be quite accurate. But that relies on a student's or a person's having enough data. So the one's ability to create, evaluate, analyze, apply is based on the data that they have memorized. So what gets avoided, or what they're trying to ignore in education these days, is the discipline and task of memorization.
We're not so concerned with knowledge, but we're concerned how you use knowledge. And I'm sitting there forming questions in my mind. Wait a minute. Well, if you don't have any knowledge, then how can you use it about it? And talking about educational progressivism, which was not a term I was familiar with. Progressivism is based on this emphasis on psychology that develops at the end of the 19th century. And you see it in people like Dewey, the philosopher William James, who basically wanted to apply psychological principles in the classroom. And so the term child-centered education, this has always been sort of the clarion call for the progressive education movement, that they want to fit education to the child rather than fit the child to anything. I think I said last time we talked that they were interested in developing the child, whereas what classical education wanted to do before that was to form an adult. And so you have all these psychological principles, and what that developed into, for various reasons, was whole word methods of reading instruction, methods of math instruction that try to do away with drill and practice and memorization and those sorts of things. Those are one of the things we heard over and over again in the rhetoric that came out of our education reform was that we want to emphasize higher order skills, not lower order skills. Because they took Bloom's taxonomy of learning, where he was just talking about how at the lower levels you do more basic things, lower order skills, memorization, all these things. Or at the higher level, you use analysis and creativity. And so what the progressives did was misinterpret Bloom's taxonomy. And they interpreted it as saying that the higher order skills are good and the lower order skills are bad, which was a nonsense. This is a back away from basic skills is what you're doing, and this is going to have consequences. I was in public policy at the time. I was getting calls in my office from teachers fourth grade teachers. I got a whole bunch of calls from fourth grade teachers who were saying, I'm getting kids in from primary school and they don't know their basic math facts. They don't know how to read. They don't know basic stuff. And the whole emphasis on content, knowledge was being sacrificed as well. So on both sides of the arts, science, skill, content equation, kids were suffering. Because knowledge was not important anymore. It's how you use knowledge. So they weren't teaching them just basic history facts, basic all this stuff. So this is what was happening.
And so what modern educators, and I don't say that in a complimentary way. It's in a descriptive way. What modern educators are trying to do these days is say, oh well, we need to encourage creativity. And analysis, and avoid such basic skills as remembering and understanding. I mean, we don't want to waste time remembering and understanding things when we could be creating and evaluating and analyzing, right? So they're trying to push students to the top of this pyramid, which is Bloom's taxonomy. They're trying to push students to the top of the pyramid. And to avoid, rote memorization, because they think that that's going to prepare these students for the future. And it's exactly wrong, because if the students don't have any basic knowledge and skills and discipline, then they're not going to be able to manage information, which they would then use to analyze, evaluate, and create.
One of the things we heard over and over again in the rhetoric that came out of our education reform was that we want to emphasize higher order skills, not lower order skills. We're not so concerned with knowledge, but we're concerned how you use knowledge. And I'm sitting there forming questions in my mind. Wait a minute, well, if you don't have any knowledge, then how can you use it?
So the pyramid is a pyramid for a reason, and that is the foundation of that pyramid is data. And so in the video, I used the example of in our medical school, for example, in our ethics class specifically, we had lectures on ethics that were just nonsense. We never studied the core pillars, which typically are at least 4 up to 7 pillars of ethics. We never studied the core pillars of ethics. But then we would have these breakout sessions where we had to get into small groups and perform these stupid exercises in front of our professors where we were analyzing cases and evaluating cases in medical ethics, but we never had the core knowledge. I had learned the core knowledge in chiropractic college and naturopathic medical school. So I had that core knowledge, but I was aware that my fellow students didn't have that core knowledge. And then, even though we had skipped the foundation of medical ethics, we never actually learned and memorized the core pillars. We were supposed to then donkey around with these stupid cases, with the idea being that we had skipped, the basic memorization because we're too sophisticated, and we were doing higher order thinking, but we didn't have the core knowledge. So that actually, my criticism of Bloom's taxonomy, which was rather spontaneous, centered around 2 things. One is how students these days and doctors these days, a lot of them don't have the core knowledge.
one of the things we heard over and over again in the rhetoric that came out of our education reform was that we want to emphasize higher order skills, not lower order skills. We're not so concerned with knowledge, but we're concerned how you use knowledge. And I'm sitting there forming questions in my mind. Wait a minute. Well, if you don't have any knowledge, then how can you use it?
How students these days and doctors these days, a lot of them don't have the core knowledge that would help them more effectively engage in the questions that are in front of them every day, especially in this discussion focusing on the medical management of chronic pain. So, and we all know that. We all know that allopathic, medical, osteopathic physicians, for example, in the United States, but in most countries, don't have any knowledge, don't have any study of nutrition. That's well documented throughout time and throughout even the educational specialty journals in like academic medicine. Within medicine, they all acknowledge that, hey, we've skipped over nutrition, and we continue to do so. So they don't have, the medical profession, doesn't even have the knowledge of nutrition. Sorry, I have to erase that. That was just too bad, sorry. I haven't had breakfast yet. Speaking of nutrition. So I'm on the right track here. I'm just trying to put the pieces together because, like I said, it was a spontaneous video, and now I'm doing this one somewhat spontaneous on top of it. So let me tie it together. Let me tie it together right now. Let's use a different color. I'll go with purple. So without a sufficient memorized foundation of that data, specifically including nutrition and functional concepts, rather than pathology-based concepts, I would reasonably argue that without a broader education in medicine, chronic pain and other conditions will be mismanaged because this step has been skipped. What I'm going to argue right now, and I'm right on this, I'll show you how I'm right in just a moment. What I'm stating is that this educational model is a problem because it denies doctors the ability to understand effectively exactly what's going on. So certain conversations in pathology, disease, and disease treatment and patient management, certain conversations could only take place based on the research and the science that we have right now. They can only take place if we also include functional components such as nutrition. If that data is lacking, then understanding will also be lacking. And the consequence of lacking understanding is that doctors will be forced to go from perception to action, but without understanding. And the truth of that was actually published 25 years ago, 25 years ago, in an article in the British Medical Journal. So this was August of 1999, the 7th of August, 1999, in the British Medical Journal. The article was titled, Analysis of Questions. This segues perfectly with what I've been constructing here. Analysis of questions asked by family doctors regarding patient care. Analysis of questions asked by family doctors regarding patient care. Results. The taxonomy. So remember I was talking about Bloom's taxonomy and how boring that is and how I think the model sucks because it doesn't include predictive ability. I'll try to get back to that in a moment. The taxonomy of generic questions included 69 categories. The three most common types, the three most common types, comprising 24% of all questions, were: what is the cause of symptom X? What is the dose of drug X? And how should I manage disease or finding X? Maybe I'll read that again, but I want to overlap that research from 25 years ago with exactly what I'm talking about now in this video. What those statements represent, what those findings represent, is that doctors had been trained to go from perception to action, but without the intervening understanding. So, as you all know, if you look at medical textbooks, so for example, like in my case, I've looked at a lot of medical textbooks because I went through 3 doctorate programs and I had to study pathology 3 times. Not including independent study, which of course I've done, but also that doesn't even include the kind of personal time study used for studying for board exams, etc. So what I noticed every time I had to study pathology is that the diseases were described almost always as idiopathic. So if we don't have a foundation of memorized data, then we will be told, or we will tell ourselves, or the books actually tell us, that we can't understand these conditions. They're idiopathic. I think it's idiopathic. And that's exactly what's going on here. So the appropriate approach to clinical care would be perception, understanding, and action. That understanding, the intervening understanding, requires a very broad knowledge base that extends beyond what is taught in medical school, medical training, and studying for board exams. So those are, in the medical world, and well, I guess maybe in all worlds, those are the sources of information accumulation other than experience. But what is experience other than the application of the knowledge that was gained? The sources of knowledge are medical school education, which doesn't talk about nutrition, and which also teaches students that most diseases are idiopathic. Medical education, postgraduate residency training, which is just slave labor with very little actual education involved. It's mostly doing. It's doing with a little sprinkling of information on top. But the amount of detailed learning that takes place is close to zero. So you've got formal medical school, postgraduate hospital residency, and then studying for postgraduate exams and attending postgraduate seminars, etc. None of those talk about nutrition and functional components that would be required to have a really good understanding from which a doctor could then go step 1, perception, step 2, understanding, step 3 to action. My argument for years has been, and I'm just now kind of putting it together in a more solidified manner, my argument for years has been that, and maybe it was based on this because I did see this 25 years ago. My argument has been, and the argument that has been made and established, is that doctors are trained basically to go from perception to action. A lot of times in medical practice too, doctors only have 5 to 10 minutes with a patient, so they don't have a lot of mental time to process what's going on and then provide like a customized treatment plan. That doesn't happen. It does happen in the chiropractic and naturopathic and kind of boutique medicine worlds. But in fact, I actually have a document from my hospital training years. I actually have the document somewhere. It's actually right behind me. I think I'll try to put it in this video when I edit it. I've cherished my good luck in the fact that I kept this document. But proving the fact of what I just said, that doctors only have 5 to 10 minutes. When I was studying internal medicine in hospital, postgraduate hospital work, they actually told us Don't spend more than 5 minutes with your patient. They actually wrote that in the training document. I'm so glad I kept that. I think it's right behind me. Maybe it's not, but if it is, I'll include it in the video. I'll take a picture of it and drag it into the video. So very briefly, these were the instructions that I received when I was in family medicine residency in the United States after graduating from medical school, also in the United States. So, people talk about, or they glorify this bullshit postgraduate training, but look at the reality of it. I'll just show you on the following page. So again, these are the actual papers that I received. And I was shocked by this when I saw it, and I'm still shocked by it. Do not spend more than 5 minutes with the patient. So, what level of complexity is a young, inexperienced intern going to gain? And what level of complexity are they going to engage? These are hospitalized patients. So imagine having a elderly hospitalized patient who entered through the emergency department and is now hospitalized for however many days. And a young intern is supposed to go in there and try to figure this out and develop a treatment plan in 5 minutes. I just thought that was absurd, and I still think it's absurd. Also, as an additional side note, perhaps, in this same program, so this was internal medicine. So in this same internal medicine rotation, the director of the internal medicine program that I was in, one day we walked by a patient's room, and he didn't go in, he just signed my notes that I had done, because I had done the physical exam and the treatment plan. He just signed my notes and we kept going. And he says, "You know why I signed your note?" And I had some idea, but of course I had to say, "No, tell me, sir, why you signed the note without seeing the patient." And he said, "Well, that's so I can bill them, even though I've never seen them." So that's basically what he admitted as we're walking down the hall, is he basically admitted to me that he's committing Medicare fraud, because he was signing the notes on these patients, but he had never seen the patients. And so that's the level of training in accredited postgraduate residency programs in the United States. So basically, again, doctors are specifically trained to go from perception to action without understanding. Proof of that, number one, is that most medical textbooks say that diseases are idiopathic, and all you can do is just drug the hell out of these people. Number two is the evidence demonstrated here in this clinical practice study showing that the most common questions asked by doctors are, what is the cause of the symptom, which is identification. So we go from identification or perception to action, which is we're already prescribing drugs. Boom, we go from, oh, you have diabetes, oh, you need insulin. Oh, you have diabetes, you need metformin. Oh, you have high blood pressure, you need a beta blocker. And then a little bit of management, which is pretty much the same thing as action. So what this article documented is that doctors think in terms of perception and action without really understanding things. Further proof of the lack of understanding is the fact that that understanding would require more than just diagnosis and drug. Doctors would need to have a more functional, not simply pathology-based understanding of what they're seeing. And that, by definition, would require some study of nutrition. And we all know what's been well documented for decades now is that nutrition is essentially not discussed and intentionally ignored and denigrated and insulted within the medical world. So again, in the second 15 minutes of the video that I spontaneously recorded, I talked about event models, and I spent a few minutes talking about accurate versus inaccurate event models. A poor event model is perception to action, which is how doctors are trained. And in emergency medicine, that's great because, you know, the pathophysiology of emergency medicine is mostly straightforward. You're looking at infections, trauma, and acute events like stroke and heart attack. So in certain emergency-based settings or urgent care settings, the understanding is relatively straightforward, and you can go from perception to action. And perhaps arguably should go from perception to action. However, and this is the argument that I'm making, acute pain management, which I also just described right now, you can kind of go from perception to action. But for chronic pain management that by definition involves so much more complexity, it requires understanding, which requires a more functional education, which also happens to thereby include nutrition. And not simply nutrition, of course, but a more functional and complete understanding. Let me change colors. I guess I'll go to a dark green. So what I'm arguing ultimately in later parts of that video is that this deeper level of understanding would require, for example, the things that I talk about in Inflammation Mastery, 4th edition. And that's in the Functional Inflammology Protocol. So it's all laid out and diagrammed, etc. And I'm going to update that diagram just slightly, just to make it a little more explicit. But it is certainly clear enough as it is. It's on the cover of the book. I mean, all you have to do is look at the cover of the book, and you can see the model. And you'll notice that all of the things that I emphasize, and I talk about drugs a little bit in the book, so I can't say that it's completely separate from the routine practice of medicine. But the topics that I emphasize in the book, the 7 main topics, or the 7 components of the protocol, all of those are not discussed in medical training. So I talk about food, infections, and dysbiosis. Obviously, infections are talked about in medical training, but dysbiosis not so much. Nutritional modulation of immune function is not discussed in any aspect of medical training. Dysmetabolism and dysfunctional mitochondria. And then we get into stress, psychology, sleep, exercise, etc. The endocrinology section of my protocol, part number 6, is actually pretty straightforward. I mean, I don't really talk about anything radical. I look at the 6 main hormones. Obviously, we have more hormones than only 6. But I talk about, the 6 or 7 main hormones and how to optimize those levels. And that's not radically different from what you could find in a good endocrinology textbook, if it's a good book. And then xenobiotic immunotoxicity, of course, and neurotoxicity, that's not discussed in the practice of medicine. So, these things do exist, these fields of study outside of what's taught in medical school. These things do exist, and they are important. And in fact, as I just said, they form the basis of my protocol. So, that understanding is available, and it directly contradicts the medical model that these things are just idiopathic and all you have to do is diagnose and drug. So hopefully I've stated that clearly enough. What I wanted to do in this quick video was orient people to what I'm talking about in the video, which, even to me, appeared a little bit disconnected. So the first 15 minutes, I'm basically asking, what are we doing and why are we doing this? Because it's not working. The second part, I get into a tangent about event models going from perception to action without the intervening understanding, which would require memorization and study beyond medical training. And that's why I talk about Bloom's taxonomy and how, the current fad in education is to take students basically skipping rules and memorization and going directly to application and problem-based learning before they've even learned anything. And that's exactly what we did consistently in our medical school. And our medical school is top ranked. And apparently it served me well enough to, score in the top 1% and the top 5% on the 4 different medical board exams that I took. So our education was excellent for medical training. But I'm saying it was still incomplete in huge chunks of, scientific field of study, the most obvious of which is, food and nutrition science. So I'm seeing how these things play into each other now, supported by this document that was published 25 years ago in the British Medical Journal. The 3 most common types of questions, comprising 24% of all questions, were what's the cause? So that's perception. What's the dose of the drug? So that's action. And how should I manage this? Which is also action. But not skipping the step of understanding. Because if you look at most medical textbooks, we are taught that diseases have mechanisms. This is also a distinction. Diseases have mechanisms, but they don't have causes. That's precisely what you'll see if you look at a big, fat medical pathology textbook like Robbins' Pathologic Basis of Disease. If you look at a book like that, you'll see that it hinges around mechanisms without understanding causes. So in other words, the assumption is that the game is already in play and all you can do is just manage mechanisms and, prescribe an anti-inflammatory drug for this pathway, prescribe another drug for this pathway, prescribe another drug for this pathway. But the assumption that's presented in those books is that the game is already in play and all you can do is try to intercept these pathologic and inflammatory footballs that are already in the air. So, the practice of medicine has basically become messengers and events are flying around in the air and you're supposed to prescribe an interception here, an interception here, another interception somewhere else. So you're supposed to spend your professional life as a doctor intercepting footballs, but not really ever understanding or controlling the game. I said that 11 years ago in a presentation that I did in the functional medicine world. That was the first time that I introduced that idea of what I call intercepting the inflammatory football. Conclusions. Family doctors in this study did not pursue answers to most of their questions. Questions about patient care can be organized into a limited number of generic topics, which could help guide the efforts of knowledge-based developers. So, in the world of postgraduate medical education, what they just described right there is what we call the knowledge gap. And that's exactly what it is. The knowledge gap is what exists between perception and action when doctors are taught that diseases are idiopathic and mechanistic, but don't have an originating cause or a group of causes. If they haven't received any training beyond diagnosis and prescribing, which is also represented by the fact that they haven't studied basic nutrition, let alone food, infections, dysbiosis, especially dysbiosis. I mean, infections are relatively straightforward. Dysbiosis is not straightforward. Nutritional and modulation of immune function, dysmetabolism and dysfunctional mitochondria, stress, diet, stress, lifestyle, sleep, exercise, etc., as I discussed under the sixth component, S, hormonal and endocrine imbalances, and then xenobiotic immunotoxicity and neurotoxicity. If doctors don't understand some of those things, then they're going to have they won't be able to truly understand disease causation, and therefore that knowledge gap will persist between perception and action. And in my opinion, again, that's exactly what we see with the medical mismanagement of chronic pain. And that is, doctors are going from perception to action. Oh, you have pain? Let me provide you these analgesic drugs. But not really understanding that that's not the appropriate approach to these complex diseases that have multiple components and multiple systems and then result in pain. If all we do is use pain-relieving drugs, pain-relieving drugs, pain-relieving drugs, then we haven't stopped the intervening disease process. So again, that explains part of my criticism of Bloom's taxonomy, which for them, in their model, the top of the pyramid is creation, evaluation, and analysis. For me, the top of the pyramid would be the ability to predict the future based on pattern recognition. So let me remember one more thing that I wanted to add to this, and then I'll close this out. Why? The answer may already be obvious through my discussion. Why would the people who control education internationally, why would they want to limit your education to analysis, evaluation, and what they say creation? Produce new or original work is what the description says. Why would they want to limit your abilities to that instead of going to the next step, which would be prediction of the future based on pattern recognition? Why would they want to stop there? Because they only want you to be able to use what you've been taught. Because if they control what you're taught, then they also thereby control the limits of your ability and the limits of your ability to even think, really. So you can see another way of interpreting Bloom's taxonomy is that it keeps people trapped in the knowledge base that they've received through formal education. And we all know that formal education is highly controlled and filtered. So another way of saying this is that the best you're going to get out of an education based on Bloom's taxonomy, the best you're going to get is the ability to be a slave to the same system that educated you. My model of a more liberating style of education is that it should include a robust knowledge base that provides you enough data points to then perform a competent pattern recognition that not only solves the problems of the moment, but also helps you see what's coming or what could be. The fact that Bloom's taxonomy is the dominant international model of education, and it is designed to keep people trapped in what they were formerly taught. If what I'm saying is true, then we would expect to see that reflected in the practice of medicine. And that article from 25 years ago proved exactly that. And the ongoing mismanagement of chronic pain by the medical profession also exactly proves my point. They can't think beyond what they've been taught. And what they've been taught is that chronic pain is an extension of acute pain, and that the way to treat it is with analgesic drugs. That's what's represented in the current practice guidelines, which I analyzed from American Family Physician 2021. It's also exactly what was taught to us in our medical school. I graduated in 2010. And it was also exactly verbatim shown in the video presentation from 2018 from Harvard Medical School on the science of pain management. So I'm on the right track here. I just wanted to connect a few things to make sure that we all, including me, understand, as I started to spontaneously develop that conversation, I went from asking, what are we doing and why are we doing this, to looking at event models, because I was trying to understand what our perception is, what is our perceptual approach, and what should be our perceptual approach. And those apparently are two different things. If you look at the medical mismanagement of chronic pain, it goes from perception to action without a comprehensive intervening understanding. The knowledge gap that exists is in the components that aren't even taught within medical education, residency training, or postgraduate education, per se. You can find exceptions. So that knowledge gap is going to persist, especially when doctors are already taught that diseases are idiopathic, not having a specific cause. And again, if you look at the medical pathology textbooks that we've all read, they focus on mechanisms but not cause. So the idea is that you're supposed to walk away from the study of pathology with an idea that this disease is already happening and there's nothing we can do about it other than understand the mechanisms to then prescribe drugs that basically intercept the inflammatory and metabolic mediators that are already in play. Again, the assumption is you can't do anything about the cause. So I think I've stated that hopefully sufficiently clearly now. Of course, I'll compile these video components. I'll edit them as I'm reviewing the edits. I'll either make additional written annotations or perhaps insert another short video, but probably not. So I think that right here I've discussed what I wanted to say. What's going on? Why are we doing this? Talking about event models, but also connecting exactly how our dysfunctional event models are a result of our dysfunctional education in medicine. And that's what's driving these problems. These problems being the expenses, consequences, and inefficacy of the medical mismanagement of chronic pain. So I'm going to continue to focus on these topics for the next few months, actually. So that's my dedication this year, is to embellish, refresh my material on these topics. I'm going to start with a quick update of my information on migraine, then fibromyalgia, and then get into chronic pain, specifically neuropathic pain like complex regional pain syndrome, which I actually had that condition. So the irony is that in 2016, the same month, literally the same month that I published Inflammation Mastery 4th edition, which was March of 2016, that same month, I published a letter article in Nature Reviews Rheumatology discussing that the neuroinflammation in complex regional pain syndrome and fibromyalgia was multifactorial. That was 2016. So there I was in 2016 writing about chronic pain, fibromyalgia, and complex regional pain syndrome. 4 years later, I actually had that disease. So, obviously then I had to take my study of that topic to the next level, because it wasn't just an abstract concept. I actually had the disease, and I was partially paralyzed for a few months after an injury that, like I said, also resulted in complex regional pain syndrome. So the information and experience that I gained from having that condition and the insights that I literally had to learn in order to basically save my own health and my own life, that's what I'm going to discuss in the upcoming work on chronic pain and neuropathic pain and complex regional pain syndrome. So that's what's coming. All of this is preparation for that. And thanks for your attention, and I'll try to keep getting these videos out as soon as I can, because these videos are going to be kind of the sources of some of the concepts that I discuss in the book as I'm trying to address the knowledge gap that exists between perception and action that's leading to, finally again, the medical mismanagement of chronic pain. So thank you very much. This has been Dr. Alex Vasquez coming to you live January of 2024 from inflammationmastery.com and healthythinking.substack.com. Thank you much.